So Michelle, Kathia, and Paula come on camera so that we'll give class now. Week 3, we're 1/4 of the way through, and we're a week before the first exam. The first exam, I want you to be aware of, there are a lot of theorists on it. I did a review just before I come to class, so it is a good review, and I talk a lot about the theorists and those key things that you need to understand. So hopefully you'll get them right. There's 7, 8 questions just on theorists, so you need to know apply them. Remember, Freud is anything sexual, right? Oral, sexual, sexual latency, sexual anything. That is all about Freud. That's the type of questions that you'll think you'll receive on him. Let me see, where is that? Okay, there you are. I'm hearing some background, so I'm trying to see where it's coming from. All right. So this week we're going to do chapters 22. Remember, there is NCLEX questions that are due. And the thing about these NCLEX questions, and I've already received some questions regarding it. When you go to Saunders and you pick out your questions, etc., on the right side where it says the category, it is not under pediatrics. It's under growth and development. It's a separate category by itself. It's the only time you go there. And then you down drop it and do infants, toddlers, preschoolers, school age, adolescent. And then you'll get the amount of questions you need. Okay. That was a question I even had today. So if you have problems with it, let me know. I can show you. We can share screens together to get it in. Now, if next week I see that you haven't done the growth and development ones, you'll see a 0 in your NCLEX as points. But I'll send a little note. You did the wrong ones. There always is one student in all of my classes, maybe one, maybe 2 in all of my classes that do it. So I try to forewarn you, but it does happen because you guys are so busy with so much going on. So any questions so far? All right. So again, this week is your what we're going to do is your exam reviews all week long. I'll be taking the same announcement and I will be just updating it so that you only have to look in one place for all of the reviews. I think that when we put it in 100 different places, you don't see it. Let me see. All right, give me 1 second. So here we go, all these adaptions. So we're going to go into a bunch of stuff. You'll always see the objectives. Now, one of the questions you're always going to see, and especially pediatrics, is all about informed consent. Know that a child who's 18, cognitively aware, they sign their own consent for emergency treatment or medical care. And remember, you have to ask permission from the child to see if mom and dad can get what's going on and listen to the results and get the results. A parent cannot call in and get the results. It must be the child, okay? And that's what that's all about. Remember, identification is so important. We weren't as picky as it years ago, and we found out there was a lot of medication errors because we were going room numbers 22B, bed B, or 232, room A. And we found out that if we had ID bracelets, it does better. And now with all the computers and the swiping and coding, we have decreased the amount of errors like crazy. We know that children, especially younger children, we do give the parent or the guardian a bracelet so that they can call in, get, information, and they have that on their bracelet to call in, plus through security, etc. So ID bracelets are important. They're actually a lot of the units will even do like monthly ID bracelet checks, and they do quality assurance on it, making sure every child in there has an ID bracelet, because you need them in order to give medications, treatment, procedures, anything. Now, safety is always going to be a big deal. And safety and infection control, always big questions on exams, HESIs, and your NCLEX, okay? So, children, what are some safety things? Well, never leave a child in a crib with the side rail down. They will roll off, even if they're bigger children. And they get caught in it, they break their legs. I've seen not nice things happen from it. So, make sure it's up. The picture that I chose for this is a hooded one. Toddlers climb, right? And we don't want them to climb and fall out because that's even higher up. So we have like this cover on top. So you put up the side rails and they are locked in. They can't get out. Again, we're going to identify children by their ID bracelet, never by their room number. And, we've done it for years. I remember me when I first started nursing. Again, the bubble tops, like I said. Now, another thing is put those cribs right up against the wall, and that's right next to the oxygen, suction, bamboo bag, the code blue button, right? We need to make sure that we don't have it so close that they can get in. They can take the bamboo and the cord and wrap it around their necks, or they can hit the code blue button, and then when we really need them, they've already done it 3 times. Nobody comes running quick. It's like Peter and the Wolf, right? So you got to be careful about that. And there's always an electrical socket there for some plug. So make sure we're have it away from the wall that they can't get into it. Children's toys, anything that goes in the crib with them, make sure that it doesn't have sharp edges on it or little pieces that they can swallow. Um, what if they had a febrile seizure and they're just moving, right? And there's sharp toys, they can get scraped up all over, and we don't want that. Medications, and all of those solutions, saline, et cetera, we need to make sure that that is not anywhere where these children can get to it and hurt themselves. All right. We don't leave medications at the bedside and then come back and give it. Nope. We give it or we take it back with us to the medication room. When we're working with kids, they love toys, and we want to be nice and share, make sure that there's proper cleaning in between bringing it from one kid to another kid. Like I've always said, like with toddlers, especially daycare, what do they do all day? It's toy to toy, right? And now they're swapping spit and germs all day long. And if they're in a hospital, they're already sick. We don't want them to get any more germs, okay? And then if we're ever giving oxygen, remember there should be no flames in there. It supports, combustion. So making sure if it's a tank, it's in a proper container so it doesn't fall over. All of these things we got to be careful about. So a lot of kids like to play, right? They like to go out in the hall. They like to get on a wheelchair and they like to push them around like they're toys. Now, they're not toys. They can pinch their fingers, they can hurt themselves, and responsible for that if they get into them. If they're in a room, if they're in a high chair, a swing, anything, they cannot be left alone. Children are Houdinis. They'll get out, they'll slide out, and they will hurt themselves. I can't tell you how many kids, if they're not infectious, of course, I'll be sitting at the nurse's station in a swing, in a high chair, that the nurses can watch them. And then the child can watch what's going on. They don't feel like they're secluded in the room, especially if parents have to work and the parents can't be there. Again, with bottles, it's easy to prop a bottle. The kid can just, drink it. It's easier. You don't have to sit there and do it, but these kids can choke on it. So we never, never prop a bottle. And if they don't want to eat, you're not going to try to make them take that bottle. And yes, you're going to eat it. No, if they're not eating it, we're not going to do that. So getting kids from here, let's say to X-ray, they're in the room and they need to go down for a chest X-ray. How do we get them there? Well, either us as nurses or nursing assistants or a transporter will come up and get them. And it's pretty neat for a toddler to go down to X-ray in like a red wagon, a red flyer, right? I know the pediatric hospital I worked at, they had all sorts of things like this, and it made it less threatening. And they had straps and harnesses to harness them in there so they wouldn't fall. So we need to pick the appropriate one. The babies, the tiny ones, especially the newborn ICU, take the whole tiny little cribs with us instead of, trying to do any other sort of thing. And if the mother, really wants to be a part of it, you can have the mother hold the infant in their lap and they're wheeled down in a wheelchair. She's wheeled in the wheelchair. She will not walk. So again, side rails up, make sure the ID bracelet's there. And if a child leaves the unit, you need to document it. Where did they go? Who did they go with? Where did they go to? So assessment and collecting basic data. We know children are different from adults. It's not a head to toe like you would do with an adult. You're going to be able to collect the assessment as they let you. A sleeping baby, oh, I can listen to a heart rate and breath sounds. But an alert crying baby, I'm not going to be able to hear anything. So you need to sometimes it's a visual assessment. Sometimes, you do have to listen, etc. If you have a child that had a fever and you gave them something for a fever, you need to go back and check, did it work? You gave them something for pain. Did the pain medicine work? Okay. These are important things. You just don't give things and then don't mention what the results was. Patient got an aerosol, able to cough up a lot of, mucus, respiration's easy. These are things that must be documented. So when you're doing an assessment on a child, a nice, warm, quiet room where the kid's not looking around and worrying about all these other people that might hurt them, right? So especially your younger kids, trying only to expose what you need to listen to, especially small infants. They lose heat pretty quickly. So only, listen to what you need to, not just uncover them completely. Even the older kids, they don't. They're very sensitive about body parts. So again, only what you need. I always say that you look at a child first, look at the color, look how they're breathing. Are they calm? Are they stuck in a pacifier? Are they smiling? You do those things first. Then you touch them. Okay. And then you listen maybe to their breath sounds. And then the last thing I would do is a blood pressure. Kids don't like that blood pressure. It squeezes them too tight. So you don't want them to get upset with you, so do the least physical first, and then you go up to that blood pressure. Talking
Professor,
quietly, yes.
I'm sorry, I have a quick question.
Sure.
So you said kids they lose heat quick. Is that why every baby I hold is cold? Like their little feet is cold, their hands is cold, and I kind
They
of have
tend
to
to be.
wrap them up. Yeah, they always cold. I've noticed that.
The thermal regulation on the younger kids is not as good as over a 1-year-old. Babies do
Uh-huh.
lose heat very, very quickly.
Yeah, I've
Absolutely.
noticed it. Like even when they're playing, and they can be in a pretty warm environment, they still their feet and hands are like
Yep.
always cold. And if you pick them up and hold them, sometimes they'll snuggle with you or they'll get inside of your coat because they be trying to warm themselves up.
Yep. Or
Yeah, I've
maybe then
noticed
they
that.
needed more clothing put on or socks
Yeah.
put on. That
Okay.
that was something you need to look at, but it's a very good
Okay.
assessment for sure.
Okay.
So
Thank you.
children don't like you screaming and yelling and being this crazy person. They want you to be quiet, talk to them quiet, and I talk to them. And what I would do is I'm actually talking to the mother or father. And as I'm talking to the child, I'm going to listen to your breath sounds. And ooh, these sound really good today. I'm listening to all the lungs. There is these three lobes, this two lobes, or the heart rate. Ooh, that sounds really good. And you're quiet, but this gives an opportunity for teaching. It's something I've always used um, with parents, and they don't even know I'm teaching them because it's not threatening. Also, pacifier. I mean, I can't talk more about a pacifier and that soother and how it can help a child self-soothe and comfort themselves. We know smaller infants like to be tightly swaddled. That really makes them feel comfortable. So if you had to unswaddle them to do an assessment, put it back to that swaddling when you're done. As I said, this is the parent teaching opportunity, right? And of course, your assessment you're going to document as you need. So, first thing when you see a child, I always say sick appearing or well appearing. Very easy. A kid who's sick is going to look sick. Their heads aren't going to be held, they're going to be coughing, they're going to be limping, they're going to be something. A well child's going to be talking and running around, you know, from toddlers up. Infants will be cooing. But just looking at it is really an overall telltale sign of a kid.
Mhm.
When we're looking at a child and we're looking at their height and weight, you know, if you have a child who's 6 months old, we need to know what should they be able to do. Well, they should be able to lift their head. They should be able to turn completely over. What if it's 8 months and they can't do that? Well, this is something we need to report to the doctor. So we need to get some early intervention. It could be physical therapy, occupational therapy. If they're not talking the way they should as a 1 year old or 2 year old, getting speech therapy. What the beauty of children is, they catch up really, really quickly. And then let's look at the kid, the way that they are here. Are they quiet? Are they not talking? Are they acting appropriately or are they not? These are telltale signs. Or, when you're talking to smaller infants, could this be the beginning of maybe a cognitively delayed or autistic child? Are they that withdrawn, not looking at you in the eyes? These are little telltale signs, and it can help us, get that child what they do need, okay? Another thing by looking at a child is we can see if they're in pain. They're rubbing their ear, and they're grimacing. Guess what? They're probably have an earache, or they're sticking their fingers down their throat. Maybe their
Irritation.
throat hurts. Or what if their legs are moving up and down, right? That's
They got
telling you
a
something's going on. They could probably be in pain, okay? This is important things to look at. Another thing we look at is there any weird bruises, cuts, etc. This could be of child abuse. Bruises on children, um, kids get bruises, they fall down. Yes, they do. But what if it is a little bit too much? Or what if it's in the shape of a belt buckle, or maybe a burn in the shape of a cigarette? I mean, these things we actually see. So again, it's us just looking at it. And then, of course, looking is a kid clean. This is that controversial. Kids like to get outside and play in the dirt and the mud, and then they get hurt and they bring them in. So that's one that's sort of subjective. You got to think, is it because they were outside or are they being neglected? So, with all of the assessments, as I said, this is a great time to talk to these parents and teach them. And older kids, as you're talking to them, you'd be surprised if they understand preschooler and school age children want to know what's going on and what you're listening to. And they want to listen to their heart and their lungs, et cetera, et cetera. Many times, parents use complementary medicines, over the counter medicines. These are all very important information. Now, I'm not against any use of any type of other type of medicine, as long as the physician knows what the child's getting, so there's no interactions. I'll give you a great example. What if a parent believes in giving garlic and garlic tea to their children? They feel it helps with something. Well, what if that was a cardiac child who was on Coumadin? it's going to make them bleed even more. So, G's, prolonged bleeding, any G vitamins. So, that's just one little example. So, as long as we know what's going on, we can say maybe there's a better choice on garlic for you because we're already on the Coumadin and let the parent know. We want to know how the kid eats. I mean, if the child is the height and weight are good, we can assume they're eating pretty good. But what if their hemoglobin macro are low? Well, it's an iron deficient anemia, maybe. It could be diet related. Okay. Do they sleep good? Are they potty trained, right? And what are activities they like to do? What do they do normally during a day? And then sometimes children have certain things like this is a more type thing that some of my grandchildren, their parents taught them. I had no idea what it was. So they look at me and just do a motion. So as a nurse, these are things if parents not there, you would have to know. Now, looking at head to toe. So when you look head to toe, again, visual, you're looking at it. Then you're going to do all of those Maslow's, the lower part of the scale. It's the temperature. Is it normal? Is it not normal? Too high, too low? Their weight, their height, blood pressure. We're doing blood pressure on smaller children than we ever did. We did do that at one time, but we found out children do have high blood pressure that require medications. And if we have high blood pressure and don't treat it, it's going to kill the kidneys, right? Just like older people. So we need to watch it. What does a pulse rate tell you? Can tell you if they're in pain, can tell you if there is a fever, can tell you if they're dehydrated, right? Very important clues. Respiratory rate. Is it normal for the child? Is it, breathing too fast? What do they sound like? Um, Also, the hydration status. Not only is it a heart rate, it's how many wet diapers today, um, skin tenting, looking at their mucous membranes. Is it dry? Capillary refill. All of these things give you clues to dehydration. They come in with vomiting and diarrhea. That's something that you do really want to know. And you're going to listen to those bowels. Is it hyperactive? And that's, what's going on. That tummy's hyperactive, and that's why we're having that diarrhea. And of course, let's look at the skin. Diaper rashes are a big thing. They're going to keep that child awake at night, and you do. So, looking for those things and giving some tips on how to take care of it. So pulse and respirations, we know that the most accurate on children is absolutely, the apical. We can listen to it there. They say that up to 5, you should listen to their apical pulse. After that, you can listen to them many other different places. Okay, radials above age 5. The respiratory rate, is it slow? Is it fast? Is it irregular? Is it abdominal breathing, retractions? All of these things are going to tell you if there's a problem. I mean, in infants, if you see nasal flaring and you hear a grunt at the end of each breath, that is an infant who's in severe respiratory distress. Again, the heart rate going up, temperature, they're going to need more oxygen. They're going to tire out quickly, right? So they probably need more frequent rest periods. And again, with infants, they don't want to be touched. They don't like it. I always say a sleeping infant is my friend because I can go and listen to those respirations, listen to those breath sounds, and I can listen to that heart rate. The blood pressure comes in many, many different sizes. It goes from extra large that I take as an adult down to a 00. And these are for that little infant you see there. It goes on my finger, my thumb, and it takes accurate blood pressures. It should be 2/3 the width of the arm. The electronic blood pressures of today make our lives so easy. I never had them as I was in the beginning of my nursing career. So I love them. Blood pressures are lower on children. Heart rate, respirations are higher. As we get older, blood pressure numbers come up to that 120 over 80 normal, and the heart rate of 140 over 60 goes down to 60 over 100, which is adults, right? And it's that difference. Blood pressures can be taken on the arm or on the leg. Honestly, on your children, especially your toddlers and preschoolers, I like doing their lower leg. It's less threatening, and I can distract them to get a good blood pressure, okay? Because if a infant is crying, you're not going to get an accurate blood pressure. So fevers and using of, these antipyretics. It's like, do you give something for fever or not? Well, giving an antipyretic doesn't do anything except makes that child feel better. How do you feel with a fever? You feel icky. You feel you don't want to lift your head up. You don't want to move. But once your fever comes down, you feel better. And as a child now, that child's going to drink now and eat. And it's those drinking of fluids is what you want that child to do. So we want to get it down. We know that it's all about prostaglandins that are being released that causes these bad feelings. So all you need to know about antipyretics is that fever increases heart rate, increases respiratory rate, makes you feel not well. And these antipyretics will keep them down. I even had my daughter's um, sister-in-law had a baby that actually I was over watching there Saturday night. And she said, I think she feels warm, but she looks like she hasn't been eating good and this and that. I said, what are you waiting for? Give her antipyretic now. And once that antipyretic was in, half hour later, she was a different little baby. Now, hyperthermia is not with a fever. This is a baby, let's say, left in a car with the windows up and it was hot, and you found them and their temperatures are 105. And this does happen, okay? So this has nothing to do with prostaglandins. Antipyretics are not going to work. This is a child that's going to be put under a cooling blanket, whether it's ice packs underneath the arms, the groin, or bigger children, the blanket. And then we do continual temperature monitoring. Now, there's all different ways of doing temperatures. No, when they first came out with these, they weren't as accurate, but today they really are. Whether it's the temporal one, whether it's the little electronic, I like the little dollar store, little click electronics underneath the arm. They work just beautifully for me. You don't need these fancy things that cost a lot of money. Um, they used to have just the little glass ones with mercury. I don't recommend them anymore because they break, and the kids bite them, and now they got mercury poisoning. So we don't have glass thermometers anymore. And even hospitals today have that little dollar store looking electronic thermometer, and they use that on the premature all the way up. So how do we do it? Well, in the mouth, underneath the arm, we have the temporal one, the tympanic one, and core is actually what we use with the cooling blanket. It's a rectal probe. We don't use that on the tiny, tiny kids because it can cause tearing of the rectal mucosa. Older children can tolerate it, and that would be a continual monitoring of the temperature. Now, pain. We've talked about it. Talk about it again. Flack. Flack is for ages 3 to age 8. And this is when flack, excuse me, faces is ages 3 to 8. Preschoolers, they can point to a picture and they'll tell you. And let me tell you the thing and the beauty about children, they don't, everything is not a 20 in pain. They tell you exactly what they hurt. If it's a 6, they'll tell you it's a 6. They won't make it a 10. Okay? They don't lie. Now, flack is for your children under age 3. So infants and your toddlers. Also, nonverbal children. And what we do is we look at the face. Are they grimacing? Are the legs moving so you know something's going on? Are they laying there and not moving because they hurt so bad? And are they crying and you can't console them? Those are the things that we look at, and they actually are really, really accurate. It must be done every shift, and we say it's the fifth vital sign now. Now, weight. Weight's important with children because they gain weight so quickly. And we know that weight is telling you, are they getting enough nutrition? It is that first telltale sign of, okay, this child's getting enough nutrition. Cognitively, they should be where they should, normal. Okay. And that's when they start ruling out other stuff when they're not where they should be. But weight is always number one. Also, this is how we give safe medication doses in a hospital, the doctor's office, or urgent cares. So we have an accurate weight every time they come in. So infants doing a height, well, you can't, have them standing up or holding them up. You lay them down on the stretcher or the bed, and then you would take a little measuring tape and you hold it at the head and you go all the way to the toe, and at the heel of the toe, you draw a line and you measure it. How much is their height? After two, you can have them standing up. Getting a 2-year-old to stand under
Professor, you're
that thing
going
that
in
comes
and
down.
out.
Am I? Is anybody else having me going in and out?
You were staggering. It was like you go. I'm not sure what happened, but it's better
Okay.
now.
Okay. So children at age 2, to get them underneath that thing that comes on their head, they get scared. So I would actually go under it first and show it. And then there's usually on some of these things a number. So I say, I'm a number 7. What number are you going to be? So now I made it a game. And then they will get up, turn their backs, and they will get a proper height. But it is scary to them. Now, head circumference. We do it over their forehead. It's above their ears and completely around. Why do we measure head circumference? Well, I'll tell you a couple reasons. Well, at birth, the heads are bigger than their chest, right? And then by about a year, year and a half, they should be equal or the chest should be bigger. So that's one thing we're looking for. Number 2, what if they're getting fluid on the brain and it's growing too big? Now we recognize it really early. Or what if it's not growing? That's another thing. There's something going on in the brain. It needs to expand as this child grows. So all of those things would have to be inspected more close. Now, getting specimens. Now, specimens on infants, the thing is to do it one time, do it right, or you're going to have a parent really angry at you. And I'm going to explain. What if you had to draw blood on an infant? You didn't label it right. You send it to the lab. They call you up and say, these specimens aren't labeled. I'm throwing them out. Get another specimen. Are you kidding me? You have to go in and redo the specimen. So it's something that you learn really quickly. Whether it's urine, whether it's a nasal swab, throat swab, does not matter. Make sure it's labeled correctly with the proper requisition in a biohazard bag, sent to the lab in the proper way. Is it through the tube or does it have to be hand carried there? Make sure it's done right. Now, all sorts of specimens. I mean, can you imagine a cerebral spinal fluid liquid that you didn't label that you sent? That's probably the worst of all of them. I've never had it happen, but I've heard of it happening. And the nurse had to go beg the lab to accept it. And that has its own issues too, doesn't it? Anyway, anything that comes out, any liquids, can all be analyzed for certain things, okay? Now, when we're looking at diapers and a urine. We can't take the diaper and squeeze it for a urine specimen. Now, we can for a bedside take a little drop to put on a stick to look at glucose or protein, which is done in newborn ICU all the time. But if we need a specimen, it needs to be either a catheterized specimen on an infant or we put a bag on when it's not for a culture. If it's for a culture, the best is a catheterized specimen because you're getting the urine, not skin contaminants. And we don't want to have to treat again and again with antibiotics because we had the body's type of germs came off on that urine and it's not what the baby had. We want to get it the first time because they don't have a strong immune system backup. So a 3-year-old's admitting, a nurse is admitting a 3-year-old boy with a high temperatures, restless and crying. What safety measures should the nurse institute on admission? Well, what are you going to do for a 3-year-old boy who's crying? I'm going to have mommy hold him, number one,
Try to
right?
figure
I'm
out a
gonna
day
talk to him
calm
and try
down.
to calm him down. Yeah.
And with the temperature, does he hurt anywhere, right? Because
Yeah.
temperature could be in usually a lot of times his ear or throat on these kids.
You
And you want to get them cooled off as quick as you can, right?
We
You want
want
to,
him.
I was gonna say get the temperature under control first, like with some Motrin or Tylenol or something, and then
oh, absolutely. Remember, you cannot give ibuprofen to a child until they're 6 months old.
so what is it, Motrin?
Oh, I didn't know that. Okay, thank you.
You cannot give ibuprofen to an infant less than 6 months old, only acetaminophen. There is
Tylenol.
something with ibuprofen and platelet coagulopathy and bleeding, and infants can't tolerate it. But at 6 months, you can give it to them. Okay? A 3-year-old can have either or. Again, restless, crying, get that fever down. I would also, if they're able to eat, give them a popsicle, cold them down, or take off some clothes. Those are all the little things we can do. All right. Children and medications. I've mentioned it. It's like, and this is also in your review. There is a lot of differences between older children and adults and the young kids and your elderly, right? These other end of the spectrums. Children are born, their liver, their kidneys, all don't work that well. Their tummies, the absorption, their GI tract. So we have to remember this as we're giving medications. It could be delayed absorption, and then all of a sudden you're toxic. So again, understanding that will make us give the lower doses of things, not giving higher doses of medication that can hurt them more. So gastric influences. Do they have all the gastric juices? Intestinal. Does their GI tract absorb? Under 6 months, we know it's not mature yet. And even after 6 months old, they still have a hard time digesting a lot of things. Putting ointments on children, no big deal, right? Well, it can be. I've actually seen a little 9-year-old boy who had a rash from head to toe, and the father, and itchy, the father put Benadryl ointment from head to toe on the child, but he gave him a dose of Benadryl too. The kid came in catatonic. Yes. Now he's okay because we just, let it sit and it wear off. But with ointments and creams, less is best, more is not better. Okay, because they absorb it really a lot through there. And remember with parenterals, anything with a needle, IV, once it's in, you can't take it out. So know the doses you're giving so that we don't overdose. So we know where does medications be metabolized? It is the liver. And it's, look, up to 2 to 4 years of age where the liver is more mature. So metabolizing, getting to where it needs to use. Important when we're fighting infections and other things, okay? Excretion, kidneys. Again, kidneys, less than age 1, very immature. So you've got this kidney that's not excreting it, which means more medication staying inside longer. So then you're giving another dose. The doses now, again, you worry about toxic doses on these children. So between the stomach not emptying, between that GI tract, and it's the same thing with adults. It just runs through because all of, their life with bowels, their intestines don't work as well as they should. Kidneys are the same there. The liver, again, still takes 2 to 4 years old for it to work, and then the kidneys, you got to really be careful with giving medications, which means you need to know what side effects of these medications are, what to look for. So you're looking for it, and again, documenting positive and negative responses. You gave a dose of IV antibiotic and you document no rash, no untoward vaccine, whatever you want to put. Okay? Given Tylenol, fever's down, baby's now playful, drinking fluids. This is important that we document those sort of things. And the one thing about children and giving doses, I would always have them check almost everything with me because I don't ever want to make a mistake because I have a moment of, gee, I pulled it up. I mean, I've seen medication errors because the nurses didn't check things that weren't really double checks. And then things happen to infant children. So I've always been that person to check and double check doses. So parent teaching, again, the one thing I always tell them with teaching, especially mom and dad, and sometimes grandma's in the house. I always, especially like for fevers, I would have a piece of paper with their medications where they have the acetaminophen and the ibuprofen, and whoever gives something to write it down and the time so that no double dosings are giving. That's a great trick. Also, if you have somebody who is, has to take these medications every day at a certain time, it's, making sure they document so everybody knows it. It's like what we do at a hospital, but it keeps that parent, in control of it. Also, children that are older should be encouraged to be compliant, as in they do the documentation and they filled it up. And we also make sure, do they know how to do 4 mLs in a syringe or what a teaspoon is or whatever the dosage is. Let them show you that they know how to pull it up correctly. So oral is always a preferred way. Parenteral, children don't tolerate them as well as by the mouth, right? Nose drops, ear drops, eye drops, they don't like to be bothered. You have to hold your head back if the nose drops, them sit there for 30 seconds to a minute to make sure it's in. And they have to blow their nose first. So it's quite a thing for them. Eardrops, usually putting them because ear hurts and you're down and out, up and back, right? So it hurts. And then eye drops, they don't want you putting them in there and they squint their eyes. Again, it can be quite a chore. Again, I've always made it into a game. Rectal usually is your younger children, and it's usually that child who don't like to take medications. We give the acetaminophen suppository, right? So it's just easier that way for the parents. They don't have to work with it. Sub-Q IM, knowing how to give them, where to give them, and then trying to decrease the pain of it. There's many ways. Distraction is big one. And then if we're giving medications, actually, believe it or not, the easiest way is IV. So they don't see you, they don't know, they don't feel anything, and it just gets given. Even orally, they have to swallow it. So we do have all sorts of peripheral, parenteral type of things. Up there on the right, it's called a Broviac. And there's port type things. And this is for a child, let's say, with small bowel syndrome, or this is a child that has cancer that we have to give chemotherapy for a while. It's that child is going to be on long-term treatment, and we don't want to keep sticking an IV in this child. It's a place to draw blood, and it's a place also to give those medications as they need. We do have those saline locks, we do have IVs. PIC lines are used quite universally today. Even have really great experts at the hospital that do them. And as I said, we have those other ones, the Hickman, the Broviac, the Groshong, and just ports that we put them in. And again, those are for those long-term medication, or maybe just IVs at night because they don't have enough nutrition. Now, IM injection, you've learned this in pharma, I'm sure of it. Infants, an IM should be no more than 0.5 mLs, and a toddler up to 1 ml. Now, IM injections in an adolescent, yes, can be given in the deltoid in the arm, but if you're giving 2 or 3 mLs, it should not be, because it will hurt and it will burn. And there's actually some medications that burn. Believe it or not, Solumedrol, which is used for like asthma, burns if you give it in the arm. So it should be given ventrogluteal, okay? And in school age children, we also can put them in their thighs too, their vastus lateralis, and 2 ml should be there. Remember, IV drugs goes directly into the bloodstream. Remember, once it's in, you can't take it out. And always monitor this site, making sure it's not leaky, not red, not swollen. There are medications that can turn a foot blue. The top of the hands come off. I've seen even heads, turn black from necrosis because of IVs. Again, that's why we check IV sites every hour. There'll always be some sort of intake sheet there. So IV fluids, again, how do you put one in? Putting an IV on a child. Now, working in the ER like I did the last couple of years, and working the newborn ICU and cardiac ICU, you're always going to have an IV. They need medications. Again, it's approaching that child on their level, and where we're going to put it. I think distraction and pre-teaching is what they need. I like to say with children that using Child Life is a group of professionals, very well educated, a bachelor degree and higher. They're taught on childhood growth and development, and they're taught the medical stuff that goes on, and they prepare the child. They know what's going on. So, and then using like numbing things, where I worked, they had this thing that it looked like a little needle, but it just poof, it blew lidocaine into the skin, and they wouldn't feel the touch of a needle. And we always used to take a joke. I bet you jumped when I, popped this thing, because it went, so it did. And getting the kids in, always have that extra help. And I always leave mommy there. Infants, I give them their pacifier, and older kids, of course, distraction, letting them look at an iPad or your phone, something. Again, all of these things do help getting that IV into that child. So here's your BSA. We know in milligrams per kilogram, going over dimensional analysis, I do dose over half times the quantity over 1. And it comes out the same way, whatever way you do your math. So how do you put the kid into the IV? I've already discussed it. Again, developmental stage, and then, where are you going to put it? You're not going to put it in a kid who sucks his thumb on the left hand. You're not going to put it in that left hand. You wouldn't do that. You're going to put it in the right hand, or even in a foot. Absolutely. And then protect the IV, but make sure that you can see it, so that if it gets swollen or leaking, that you can, stop it immediately. And, you wouldn't put an IV in a foot in a child who wants to get up and walk around because then they couldn't do that. Okay. So again, where the mobility considerations. So today we're lucky. Anytime I went to the Pyxis as a nurse and pulled out a drug, if there was a interaction between something, it would give me an alert. And I'll give you an example. Ceftriaxone, which is Rocephin, you cannot give it with the IV fluids Ringer's lactate. So every time I would push to get it, which was quite a bit, it would say, child not on Ringer's lactate. And you would check it, and then it would give you the drug. And if you didn't, they know you couldn't. Also, there's things with milk, with antacids, different things. And usually there's a label from the pharmacy that'll tell you you can't mix these drugs together. I mean, iron supplement with milk, iron supplement and egg yolks, you cannot put them together. And what it does, it stops the drug from working the way it should. Now, gavage feeding. When you think of gavage feeding, you think mostly of the little premature infants who are not big enough to suck, swallow, and breathe. And gavage feeding, we make sure that it's in the tummy. We check to see if there's any milk left from the feeding before. And we measure their abdomens, making sure that the abdominal girth didn't go up 2 centimeters, which means the food's not going down. And very slowly, we give that feed to that child. And we don't want it to be cold because it's cold through the tube in the tummy and it would hurt. So it should be just at room temperature going in. And we can give medications through there and we could give their nutrition through there. I would also have a pacifier in that infant's mouth. So they're sucking and getting their food and they're getting that feeling. Gastrostomy tubes are placed for many reasons. We have a lot of diagnoses, Pierre-Robin, DeGeorge syndrome, that their little jaws are little tiny and they don't eat correctly and they can't. So what they'll do is, and they usually grow out of it, both of those diagnoses, and they'll put in a gastrostomy tube. There's different types of tubes. The one on top is really cool because you can take off the tubing and put it away in between feeds and close it up. And it's a little mic or a button. They're called of those. The other one looks like a Foley catheter and it hangs out. And you always have, gee, is it going to pull on that child? So you always tape it or put a net around it to hold it in place so that infant or toddler don't pull those things out. Okay. So
Most of my clients have that first one. Then they're so nice when they're like up and about and moving around and everything because they don't get caught on everything.
right. And usually what I found through my career is initially they'll put in the longer one and then it's the insurance of what they will cover. So when they have to replace it, they'll put in the other one. And I've seen that repeatedly throughout my career, all about insurance. It really is. And that's, I think, sad because I think it should be comfort and safety for the child.
Because I've also found that recently, I don't know what it is, if like they're making the tubing differently or something, but anybody that has one that goes in with the balloon have been coming out like they're looser for some reason. Like all of them are leaking and everything. All of them. I mean, all my clients are adults, but anybody with a Mickey button, they stay in fine. But anybody with the ones with the balloon on the inside,
maybe it's because it's manipulated and the hole gets bigger with that
well,
moving
even the
of that
people that
tube.
like don't move at all, and like the only time it moves, I don't know if it's like they've changed the production on them or something, but they're just not as good as they used to be. And our smallest client uses the peds ones, and hers has been so loose.
Interesting, interesting. Thank you. So enemas, we never do these routinely. Now, when would we give an enema to a child? Well, my little Christian has a story for you. When he just turned 3 years old, he was being potty trained, right? Wasn't completely yet. He urinated in the toilet and he peed a little bit in the toilet, but and he was sick right during this time too. And he really didn't, move his bowels the way that he should. And all of a sudden he stopped urinating for 24 hours. And I'm like, this isn't right. And then his belly got big, so we took him to the ER. He was full of stool. So we had to give him an enema. And all of the stool came out. And then, of course, he urinated. The intestines blocked the urethra, and he couldn't poop the way he should. So that's one thing. Another thing is children, toddlers especially, the one thing they can control is their bowels. And that sometimes to get some type of, pay attention to me is they stop moving their bowels because they can control it. And I've seen it 7 to 10 days where they haven't. And the whole bowel, the ascending, descending transverse is full. And then we would give one enema just to get it through. But to give them every day, no, we won't. It's just that emergent, let's loosen that bowel up, let's get it going, okay? And they have little PD fleets for that work really, really well. And tap water, we never use it. It would always be more isotonic because it has to do with if it's tap water, it's going to take fluid out of the body, and there's this big water shift, and it's not good for that child.
So is it like a a laxative almost, Professor, but we only administer it when it's needed?
No.
No?
Okay. Think about your body. It's all isotonic. Okay.
Uh-huh.
If we put something that's hypotonic, which is water, into
Mm-hmm.
somewhere, the body wants it to be normal, isotonic. So
Mm-hmm.
it pulls stuff, fluid out of the interstitial space and puts it into the bloodstream. So it's taking out extra fluid and causing almost dehydration in that child because it's pulling out and all of the electrolytes that go with it to make it isotonic. It's a huge concept of what that
Mm-hmm.
happens. So we don't give tap water
Okay.
ever. It should only be that fleets or an isotonic type
No.
of
I mean the enema.
enema. Enema, yeah. Enema, yes. It's going to pull out all of the water and the moisture out of the bowel and put it into the bowel to try to make it an isotonic type of solution. I know it's a hard one. Okay,
Professor, I meant
respirations.
the enema.
Yes,
The
the
enema.
enema.
The
The
enema
enema
or
we
the
don't.
enema, whatever it's called.
Which one are you talking about?
Are you asking if an enema is a laxative?
An enema makes well, okay. It's something fluid that goes in that creates the bowel to have a bowel movement. Is it like a laxative? Okay. Yes, it makes you move your bowels. Yes, that's the goal. What is
Yes,
it
that's what I'm
called?
asking you.
Okay. It does do that. Yes, it does. Okay. So respirations, you can tell a lot by the way a baby is breathing. Again, you need to know what your vital signs are and what normal for each level of child, right? If they're not breathing good enough, they're not getting oxygen. They get restless. That's one of the big things. You see a child that's breathing, fast or whatever, and they're getting restless. We know they're becoming hypoxic. Something's happening. Then it gets to the point that they're becoming fatigued and then they're not moving, they're apathetic. Like, then their body's going to say, let's try harder to breathe. So now we have retractions, they're becoming dyspneic, becoming pale, cyanotic. All of these things are telling you clues to that child, what's going on. And the first thing is looking. And the next thing would be is to listen. And then, we're worried about respirations. Are they getting enough oxygen? That's when you put that O2 monitor on, right? Making sure that the number is okay. Now, when do you suction an infant, a child? Well, if they can't blow their nose and we're hearing all this noisy respirations, then the nose is bubbling or the mouth is bubbling with mucus, absolutely we're going to be doing those things. Again, we don't over suction. More suction doesn't make it better. Clear the airway enough for that child, okay? Now, there is something called a tracheoesophageal fistula. This is something that an infant would be born with. It's congenital. There is an opening between the trachea and the esophagus. So that means if a baby swallows anything, which is milk, right, goes down the esophagus, it goes over into the trachea, causing gagging and choking. So absolutely, this would be something that we would have to keep that mouth clean. We know sometimes the trachea is small, not open enough, or there's an infection going on, or the lungs aren't expanded, atelectasis. And then what if we have a trach in or an endotracheal tube? And if they're not breathing right, it could be clogged. So we need to make sure that we put a suction catheter down and get it opened. So what happens to your child will swallow the toy? What we're going to do is abdominal thrust on the older child. On the infants, it's the breast. We're going to do two, and then we're going to do the backwards thrust too. So knowing how to clear an airway. Kids like to eat things like my kids little it was almost Vienna sausage looking things, the kid ones. My son at that age was choking and I had to do the Heimlich, but it was abdominal thrust that I did on that child and it across the room. And it's something as nurses, you're going to see it. And it's going to be one of those instant reactions that you take care of. So preoperative and postoperative care of a child. Well, preoperative, a child old enough should be really aware of what's going to be going on. Teaching them. Today, we actually let parents go into the OR with them and then, put them under gas first and then start the IV and then give all the medications that way, making it less traumatic. Maybe just a little oral type of sedation first and then bringing them in. The other thing is really tiny infants. So that's less than 1 year old. We should never, ever leave them without eating, drinking more than 4 to 6 hours. They don't have enough sugar and their blood sugars will drop quite drastically. Okay. And when usually it's 2 to 4 hours at most, they're held NPO before surgery, even open heart surgeries. Okay. And what we do is to help them deal with this not eating, again, putting a pacifier in, letting them suck on that and self-soothe of it. Now, when they wake up, again, keeping that kid comfortable, explaining what you're doing, and again, pain control, making sure that child has proper pain management so they don't remember the whole experiences. I went to sleep, I woke up, and I hurt. So an infant wears a diaper, was admitted to the pediatric unit with diarrhea, which lasted for several days. The physician has ordered an application of cortisone cream to the infant's reddened buttock. Should the nurse be concerned about this order? What do you think? Reddened buttocks means blood is right there. You're putting a steroid right into the bloodstream. That is extremely dangerous.
Mm-hmm.
It's being absorbed right away. So that was the answer to that one. So
And then they're dehydrated too, especially if they had diarrhea, professor, for several days, right? Yeah.
yes, yes, yes. And hydrocortisone, is that what we put on? Now we know diaper rash is diarrhea. We need to treat it. Or that kid's
Mhm.
going to be awake and not sleep, and parents aren't going to sleep. Nobody's going to sleep. But hydrocortisone cream on red excoriated area, absolutely not. Because how they absorb it through their skin, and they absorb it really, really easily. Any questions? All right, let's go ahead and find a cahoots to work with. Anybody else is coming today? All right, let's get started. Week 3, chapter 22. After instilling nose drops, the nurse will keep the infant in the head down position for at least what? So remember, nose drops, the one thing is they need to blow their nose before, or it won't work, but it's 30 seconds to a minute. Children don't like that, and it's hard for them to understand it. So I always would have to use distraction to hold them and keep them down. So the medicine works, it goes where it has to go. When planning care for a toddler, what behaviors do we need to consider to promote security? How do you keep them happy? Their stress decreased. So remember, toddlers like routine, rituals, ritualism. They like to know what's going to happen when they wake up, when they're going to eat, when they have their bath. They want to know what's coming next. And when you do the same thing as home, these children are a lot happier and, they're not going to be as scared. You decrease their stress. According to Maslow, what level of hierarchy of needs correlate with measuring vital signs and oxygen saturations? Remember, there's a big triangle. Goes from physiologic needs to esteem. And the first thing is you need to have vital signs. You need to have food and house and bathing, right? That's all physiologic. That's basic needs. The basic thing you have is vital signs, right? And then the highest would be that esteem, something that you're good at, that you want people to see you that you're good at. The child explains to the nurse that he got sick because he went swimming in the rain. According to Piaget, what? So this is figuring things out. This is almost like the broom and the horse and the arms and the airplanes and flying around. And, you know, this is that child is something that he has seen. It could be the mother, the father. There's many cultures that believe that because they went swimming in the rain that they got sick, or they went to bed with wet hair because then they got sick. This is all concrete. Sensory motor is all about touch, mouth, and movement. Gentamicin eardrops are prescribed for a 4-year-old child. How would the nurse position the auricle? The ear, how do you do it?
Professor, my computer just died, so I can't participate anymore. I'm sorry, but I'm still on my
Okay.
phone.
All right, just listen.
Okay.
So it is up and back for a 4-year-old child, okay? So that's something to remember for you all. What is the best pulse location for the nurse to use when assessing the pulse rate on a 12-month-old infant?
Africa.
So we know it's apical and that's up about the age of 5, and that's ordered to get the most accurate, okay? So 12-month-old, absolutely apical. A 4-year-old child asks tearfully if the IM injection will hurt. What is the nurse's most effective response? Remember, with children, the most important thing is to be honest. A 4-year-old children wants to know. And yes, it's gonna sting a little bit, but let mommy give you a hug and we'll put a band-aid on it when it's done so it will be okay. I mean, remember, preschoolers are the age of band-aids, so sometimes they make everything all better. So just be honest. What antibiotic is known to cause discoloration of the teeth in young children? So this is tetracyclines. Remember, it's almost like gray. And this is in the 50s and 60s where they used to use, like today it's all about, a penicillin or Cipro or Augmentin or Amoxil. Well, that's the way tetracycline was used back then. And then their teeth would turn gray and they realized that. And then they developed newer antibiotics that didn't. A parent tells the nurse, I'm not sure how to give this medicine to my infant. How would the nurse teach this parent? And this is absolutely not an uncommon question. Parents struggle with how do they give the medicine. Remember, especially if it's their first child, they've never given it before. Now, what they say is just take an oral syringe and then you put it in the side of the mouth and slowly squeeze it in as they swallow. If you squirt it in the back of their throat, they're going to vomit all over you, okay? So you don't want to do those things. So good job. When should a child begin to be able to feed themselves using a spoon or fork? And it doesn't have to be right side up, backwards, no. It could be any way. At least they're attempting to use the fork and feed themselves. And again, this is according to the book. And that's about 2.5 years. Okay, they say it starts maybe at 2, but it's about 2.5, 3 years completely, and that's with just the spoon and fork. Should parents be concerned about how much fat they include in their young child's diet? What did I tell you about the fat in the diet in children under the age of 2? And they need it there for growth and development. It's their central nervous system. They need the fat. Even if they're large children, that's one thing we won't cut is the fat in their diet. They need it. What type of play are toddlers known to do? And it is absolutely parallel. Toddlers don't like to share. Parallel is they're playing next to each other and they're not sharing toys, they're not playing together. Associative is when toddlers play with older children, usually your preschoolers. They're playing together, but there's not a goal. And then cooperative is when they build that racetrack or build a house or build a sandcastle. There's a goal in the end. So, absolutely parallel is a toddler because they don't share. Which restraint is most appropriate for the insertion of an intravenous line on the scalp vein of an infant? The restraints are really important. Years ago we used to restrain everybody, wrist restraints, posy restraints, and there was a lot of incidences that occur. So we minimally restrained now because of all of these things. Now, we're going to use a mummy. And what's a mummy? It's basically putting them in a swaddling. You swaddle them up so they can't reach their scalp and pull it out. Okay. And that's why it is a mummy. How often should a child who has continuous intravenous infusion should be assessed? How often are you going to look at that IV? Remember, our biggest concern is IV infiltrate. So it is every hour. Think about 10 mLs and a little, less than a 1 pound infant. 10 mLs going in there, it's going to be a huge infiltrate and it could cause necrosis of the tissue. So every hour, make sure we check it diligently. What type of method is most accurate way of determining the correct dose for children for medication? In a hospital, we know we use milligrams per kilograms, mics per kilograms. That's what we do. But the most accurate way is your BSA, your body surface area. According to Kohlberg's conventional morality, school-age children believe what? So these children are pleasers. They want to do the right thing because they want to please. That's what Kohlberg is in school age children. Preschoolers are the reward and punishment. That's the things you need to remember for Kohlberg. What developmental level of Freud are school age children developing to form friendships? This is one of those words but you can rule it out by what you see here. So it's called latency. And what it just means is same-sex peers. Their friends are of the same sex. And again, we're breaking away from the family, from parents, and now we have other people talking to them about things. All the other three were all Freud, all something sexual, right? Oral, anal, phallic. That is definitely all Freud. Adolescents are all about body image. Erickson described this as what? What did I say about adolescence? Who am I? What do I want to be? Right? And that's identity versus role diffusion. Who am I? What do I want to be? Where do I want to fit in society? Which group? The drama group, the gym group, the art, the band, whatever. Those group of people do I want to fit in? What do I want to be when I grow up? And then it's all about what do I look like? Am I too many freckles, curly hair, these things? What can I do to make my body image what I want it to be? So definitely, that's Erickson. What is the final stage of Piaget's developmental theory where the adolescent increases moral reasoning? What did I tell you about those adolescents? Remember, Piaget is all about thinking. And initially, we start thinking, suck, swallow, and breathe. And then we figure out things rattle, sensory motor. And then it gets to the point of school age where concrete, they had to see it, touch it, feel it to know it or to replicate that. But these adolescents, they don't need any training. They can decide in themselves. It's formal operations. They can figure out how to get what they want and they can figure out what people want from them in order to get that. And that's usually how they use their moral reasoning at this age. A mother is concerned her child has developed a fear after an immunization. What education should the nurse provide? A fever after an immunization. Is that normal? It's absolutely normal, and I tell you why. You give an antigen, immunization, and you insert it into the body. The body reacts to it and builds up antigen and antibodies against it. And that builds the immune system. So they need to do it. Now, what would you tell a parent? Well, a lot of these are at 2, 4, 6 months. We're giving a lot to give that acetaminophen, every 4 hours or every 6 hours so that they don't have pain or a fever, and then bicycle those legs to get that immunization worked in a little better. And sometimes cool compresses on that area because it will get warm and reddened. So those are things I would teach to my parents. Which approach is best when administering an oral medication to a young child? Some children, I feel sorry for parents because they just don't want to take their medicines. And then you have this medicine that you have to give, and it's what we call a straightforward approach. It's time for your medicine. Would you like some juice or like a water after it? Or would you like a popsicle? I mean, whatever it is to get that kid to take that medicine, it's straightforward. Sometimes I'll even say, do you want the pill to chew or do you like the liquid? And you want it in a cup or a syringe, you can squirt it yourself. Those things is what you can do to help. It's not like, yeah, you need to take it now, take it. Or this one, your brother did it better than you. No, you have to be specific to the child. The nurse observes a 2-month-old infant actively feeding with a propped formula bottle. What fact should the nurse consider? Oops. And we know that if they're sitting there with the bottle prop, the chance of them gagging and choking and aspirating is quite large. So we would let that parent know that it's not a good practice to do that. 6 hours into a 24-hour urine specimen, the nurse is incontinent. Which instructions should be provided to the parents? Sometimes they're looking at different sort of minerals, in the urine, and they do these 24-hour specimens, but they need a true and real 24-hour. They have to restart it. As much and difficult as that is, they have to restart it to get an accurate, because they look at the numbers, and if you've missed any part of it, the numbers aren't going to be accurate. Which procedure could be performed to obtain spinal fluid for an examination? And that's called a lumbar puncture. I think it's probably one of the scariest things for children and parents. But again, I'd have some kids that I would say, I'm going to give you a big, big hug, and you're going to hug me back, and you're going to have the doctor feel you on the back and touch you, because we put numbing cream back there, but they might feel it when the needle goes deeper. And I've had the kids just, almost fall asleep just by hugging me because they felt comfortable there. It's a difficult procedure to do, especially on that preschool toddler age. What is the most effective position for the nurse to place a toddler in to administer medication? So they can be in a crib, they can be in a parent's arm, right? But we don't want them sitting straight up because it'll dribble out. So it has to be, the head back a little bit so that we can put it in slowly into the mouth and they can slowly drink the medication. That's what the point of that question was. What is the most significant reason for obtaining an accurate weight on a child in the hospital? So we know that we are getting a weight because we want to know the weight today on that child. Children gain weight sometimes, could be 5 pounds difference between visits. And we want to make sure they're getting enough medicine, or they might have been sick and they've lost weight. We don't want to give them too much. And last question, a multi. Which of the following statements are appropriate when administering medications to children? So we know that when we're giving medications, that chewable things that the preschoolers love, especially the acetaminophen and the ibuprofens. That's why you have to be careful and put them away because they like to eat them, especially like vitamins. Make sure that children, they're not easy to give medication to, that that you're going to have some time. You're not going to go in there and take it and come out. It's in a room. It's not going to happen. And we know toddlers, No. They're not going to do, right? That negativism. And then, of course, if you have an older kid, give them the choice. You want the juice or the water after, or a popsicle, or do you want it in a cup or a spoon? All these things can make it less threatening. Angela, good job, Angela. Number 2. Me. Number 1. Jekka. Good job, Jekka. Pardo and Mila. All right, let's get out of here. Wanted to mention one thing about your discussion questions that I was doing them. And the one thing that I saw that needs improvement on is how to do citations in the body of the paragraph. You notice most of you got 18, which means you had a good discussion post. Everything was good. But let's say you used the book Leafer, right? So at the end of a sentence where you've said information, before the period, in parentheses, you write Leafer Common 2023. And you do once or twice in that paragraph or couple paragraphs. That's all I want to see. Where did you find that information? Okay, as you go forward and want to go forward in your careers, those are going to be looking at little things like that APA, just the leafer. Now, I did put it in the comments. I showed you what it looks like. Just put it up into your next discussion question so you can get your perfect 20s, okay? That's the one thing I did see. Remember, we're doing all of the reviews this week. Make sure you try if you can to go. I did mine. I'll be posting it as soon as we get yours up today. It'll all be there. Remember, it's going to be in one place. It's going to be on one announcement, and I'm just going to keep editing and renewing it and putting it in a new review. So there's only one announcement, and I put everything in there for you again. So again, one place to look, one place to stop and shop, as I call it. Any questions about anything? Try to